Good afternoon, everyone, and thank you so much for joining in today. I'm Dr. Kim Newell-Green, and I'll be the moderator for today's virtual Grand Rounds, COVID-19 updates, and the health implications of wildfire smoke. Just a reminder that this educational series is generously sponsored by a partnership between the California Medical Association and the California Health and Human Services Agency. Next slide, please. Here are our speakers' disclosures. Next slide, please. Here's our agenda for today. Next slide, please. And just a reminder that we do provide CME for this series. You'll be sent a survey after the completion of the webinar. Make sure you do attest to your attendance, and on a completion of that survey, we'll send out our certificates. Next slide, please. So wildfires, as we know, seem to have become a yearly norm in California. With this recent rain, maybe we're getting a break for the year, but many public health experts have wondered what the short and long-term health impacts of the frequent particulate exposure are for California communities. In the past 2 wildfire seasons, scientists have also looked into the impact of wildfire smoke exposure on patients with COVID-19 infections. In this webinar today, Dr. Rohan Radhakrishna and Dr. John Balmes will discuss the evolution of COVID-19 in California, as well as the impacts of wildfire on our health. We are giving our regular presenter, Dr. Erica Pan, a short break, and her colleague, Dr. Rohan Radhakrishna, will be addressing our usual COVID-19 updates, as well as addressing the climate action for health professionals. Dr. Radhakrishna graduated from Stanford University, the University of California, Berkeley, Christian Medical College in Vellore, India, and the University of California, San Francisco. He is currently the Chief Equity Officer and a Deputy Director at the California Department of Public Health in the Office of Health Equity. Rohan supports California's COVID-19 equity work, and he leads OHE's broad portfolio, which includes anti-racism through a racial health equity initiative, advancing health in all policies, including California's climate change planning, advancing behavioral wellness and resiliency for diverse populations through the California Reducing Disparities Project, and meeting OHE's statutory mandate. He came to this work having had 20 years of experience learning from and working with impacted communities in a local health department, among other places, in Contra Costa County, where he served, among other things, as deputy director and as chair of the Department of Family and Adult Medicine at Contra Costa Health Services, where he still practices family medicine. His local experience responding to the COVID-19 pandemic, power shutoffs, wildfire smoke, and heat emergencies has solidified his commitment to addressing the overlapping public health crisis of climate change and structural racism. Such a pleasure to have you here, Dr. Radhakrishna. Thanks for joining us.
Thank you. So an honor to be with you, my California health professional colleagues. As mentioned, I'll be filling in this month for Dr. Erica Pan, our state epidemiologist. We tag team a variety of events, and so I'll be providing the overall infectious disease update for the state, as well as talking about the climate health crisis, and in particular, what California health professionals can do. What you should know for our agenda today is I'll be spending about 12 minutes talking about infectious diseases. We already got some of your questions, and I'll try to weave some of the answers into my presentation. The hot topic in the news this week is the potential tridemic of not just COVID, but influenza and RSV as well. So I'll be talking about the situation in our state amongst all 3 of those respiratory viruses. I'll spend a few minutes on monkeypox, giving an mpox update, and a minute on Ebola as well. Next, I'll spend about 12 minutes in a summary of the CMA's October 21st panel held in Southern California. It was about the climate health crisis and what climate action California health professionals can take. And we know the problem is tremendous. As we speak, global leaders are gathered in Egypt as part of the United Nations COP, the committee of parties that are asking for more bold action, and in particular, the healthcare sector and health professionals have a large role to play. And I'll talk about that leading into the health implications of wildfire smoke, and you'll hear more from our expert here in California, Dr. John Balmes. Next slide. So for the COVID-19 update, the situation is looking favorable, and we're cautiously optimistic as we head into a plateau period. Next slide. You've seen these graphs in prior months, and on the left, the entirety of the pandemic with the multiple peaks shows our 7-day average of cases in blue, deaths in red, hospitalizations in gold, and ICU admissions in black. What you note in the bottom left-hand slide is the most recent Omicron peak in blue for cases has come down, and we are now in a plateau period. Zooming in on the top right side of the screen, you can see the tail end of that plateau, noting that we have come down in a major way, and I'll share some of those data points. Our case rates right now are at about 6.1 out of 100,000 population, and that relates to the new CDC's community levels criteria, which I'll go over where our state is at. In terms of case averages by day, we're looking at about 2,500. And the test positivity has been low at 4.1%. It's increased a touch over the past week to 4.5%. So out of 100 tests, 4.5 coming back positive. The statewide R effective with minimal regional variation is at 0.89 currently. Testing still has a fast turnaround time. 98% of tests being done in California have less than a 2-day turnaround time. And deaths are thankfully low and continue to trend downward since August. In terms of the hospital burden, as of October 30th, the hospital censuses are overall statewide at 11% above their baseline in terms of utilization, and no particular region is above the 20% threshold that cautions an impact on capacity. Next slide. So again, referencing the CDC community levels, which is being used throughout the nation, you can see over month by month, we have shifted from some counties being in the high category to the medium to now 100% of California counties and local health jurisdictions being in the low level. And this is now being used to guide our mask guidance, as you'll see towards the end of my presentation around policy guidance updates from the state. Next slide. One of the questions you all submitted was about our statewide wastewater surveillance, which allows us to keep vigilant and have an early look into what's happening. And so some of the trends we want to share with you are in the pinkish tan color. You can see plateaus in the majority of the state. And in the gold, you can see that in the Sacramento and the Bay Area, there are increasing trends which could portend an incoming increase in coming weeks and months for COVID-19 with certain variants. In particular, what you don't see with granularity in this graph, but we're picking up in the sewer sheds, is that in Santa Clara, in the Palo Alto, San Jose, Sunnyvale area, in Contra Costa, in the Pittsburgh, Antioch area, in the greater Sacramento area, in the San Joaquin Valley, Merced in particular, as well as in Lake County, there are some increases that we are starting to note. But overall, you'll see the majority of the state is in that plateau or in decreasing in tan or gray. Next slide. So getting to the topic of the potential tridemic, we will talk about influenza as well as RSV. So starting with influenza in the bottom left, you can see data from the past 5 years, each in a different color. Note orange, which is very low from 2 years ago due to the stay-at-home orders and the non-pharmaceutical interventions of masking and others. And last year in gold, you'll see a very late peak in June for one of the latest influenza seasons we've seen in many, many years. In terms of this year in bright blue for 2022, you can see that we're starting off at a higher amount of percentages of specimens that are testing positive for influenza. So currently we are at 7.9%. This is for all population adults as well as pediatrics. So this shows an early start to the influenza season in California. When it comes to RSV, which is on the top right, we also have data from the prior 3 years. And what you'll note is a concerning increase in early start, both for the pediatric as well as the non-pediatric populations. So in the red circles with the solid black line, that's our current data for pediatric populations in California, you'll see an early and a very high amount of percentages testing positive. 33% is where we're at currently in early November. And similarly for adults, which is the red dots in the dotted black line below that, you'll notice again higher than usual baseline and a continuing increase from late October into early November. Both of these are notably higher than last year, which is in green, and the year prior, which is in blue. Specifically within California, we are noticing higher rates within Southern California. You may have heard in Orange County some concerns around hospital capacity in terms of pediatric in particular. And so in summary, we are noticing an earlier and higher beginning to the RSV season, in particularly impacting infants and preschool age children. This is a reminder to physicians to recommend the flu vaccine. We're predominantly seeing H3N2, and this year's vaccine is more effective than last year. Initial data shows for H3N2 and does cover against A and B strains as well. So please message to your patients that we have a better tool than we did last year, and it's the right tool for the strains that are circulating in California. And also an important reminder in terms of co-administration. I just took my family in and noticed different lines, and some people would get one and not the other. So really messaging on the same visit, we have 2 arms. You can in each arm get the influenza as well as the COVID vaccine or the updated bivalent booster during the same visit to any vaccination site. And then finally with RSV, noting we don't have a vaccine, the importance of respiratory prevention behaviors from hand washing to staying at home when you're sick, and masking, although not required, still recommended in some regards, and with the young population as well being symptomatic. Next slide. So people are asking, where are we at in terms of vaccination? And on the left, you'll see overall completion of the primary series, so 2 mRNAs or 1 of the Johnson & Johnson. Of eligible Californians, which is now 6 months and older, 72.4% of all eligible Californians have completed their primary series. And you can see the breakdown at the bottom by age and by race. This is publicly available on our dashboard with the link at the bottom left-hand side of this slide. And what's very exciting, just in the past 2 weeks, we've posted this updated data for bivalent boosters, or the updated boosters as well, again, broken down by age as well as race and ethnicity, with notable concern. As we get into younger populations, the rate of uptake of the bivalent boosters is lower, as we've seen with other phases of onboarding with FDA approval. But we do note concern in particular populations, particularly in Latinos and Blacks and American Indians and tribal Alaskan Natives, lower uptake. Overall, we've given 3.8 million bivalent doses boosters throughout California. So we are a nationwide leader in many regards, and yet we have to look deeper and note that from an equity perspective, we have a long ways to go. During September, our data shows that if you are unvaccinated, compared to those who completed their primary series, you're 3 times more likely to die from a COVID-19 infection. We share that information on our website as well. So clearly a strong case to encourage those who haven't yet got their primary series to still consider it, and those who have, that it's not enough and they need the most updated version for the winter to come. Our immunization branch continues to support locals with vaccine equity plans, and we are noting additional uptake with some of our strategies that have been tried and true, like CBOs, working with community organizations, schools, pop-ups, and extending hours and walk-in capabilities for vaccine access. Next slide. This is a reminder that there are so many communication and educational resources for you as providers. There's trainings on how to have the conversation. There's conversation guides and toolkits for pediatrics on the left. We continue to update these. There's special information, posters you can print for the bivalent boosters you can share in your clinical and office-based settings. And on the right is specific information on co-administration of flu as well as COVID vaccines and boosters, that it's safe and effective to get them both at the same time, and specific resources for infants and toddlers as well. Next slide. A brief note on therapeutics is that we have a concerning low rate of outpatient COVID-19 treatment, especially for vulnerable populations with the tools that we have available. We want to remind the provider community that therapeutics are in ample supply, that most adults have qualifying conditions, being above age 50, smoking, physical inactivity, obesity, hypertension, or depression, and that Paxlovid is extremely effective. Many are aware, and the initial data showing an 88% of risk reduction in hospitalization and death for the unvaccinated. What many aren't yet familiar with is the data around already vaccinated patients, that it shows a 45% reduction in hospitalization and death. And I can share from personal experience, from family members to my colleagues within the Department of Public Health who got COVID this summer. Although they qualified for Paxlovid, it was really hard to get. Shouldn't have to pull special strings to get what's available in supply to lower risk of hospitalization and death. So I want to encourage the provider community to continue messaging. You'll see a broader campaign for the public coming out this month around therapeutics. It's really an underutilized tool we have to save lives and decrease hospital capacity challenges. Of note, there are additional alternative options to Paxlovid if there's concerns around renal function, and it is proven safe and effective in the elderly. People still have concerns about rebound, and we want to remind people that the rate of rebound is low, less than 10%. It's mild, and rebound can occur anyways, even without Paxlovid treatment. So there is emerging evidence of the benefit in decreasing post-acute sequelae or long COVID from getting therapeutics and medications like Paxlovid. The decrease in viral load early on can decrease inflammation throughout multiple organ systems. That's part of the physiological plausibility of decreasing the impact of long COVID. So more studies to come, but emerging evidence shows that that's another reason to give it to your patients and encourage more communication around it. Next slide. Briefly, this is national data through July of 2022 on therapeutics and outpatient treatment from Paxlovid, showing the equity concerns. On the left is by race, and on the right is ethnicity for the Hispanic population, noting white and Black on the graphs, and overall the lower rates for Black, Indigenous, and people of color. And so this also rings true in California. So yet another reason why we want to get your participation to have more outreach and education for our therapeutics. Next slide. And so that brings us to our NIH guideline updates. This is from September 30th, and so it does show greater disease severity for co-infection. And the good news is for co-treatment in terms of antiviral agents for both influenza as well as for SARS-CoV-2, there's no clinically significant drug-drug interactions at this point for the use of antiviral agents or immunomodulators. And so it's something else to message to patients in the provider community. Co-infection is a concern as we head into the height of respiratory winter season, and co-administration of agents is safe and effective. Next. A little more detail in terms of the subvariants. People are asking about BQ.1 and BQ.1.1. They are likely resistant to monoclonal antibodies and some of the other subvariants as well, and likely resistant to the preventative monoclonal antibody Evusheld. For that reason, the NIH does recommend counseling about the risk of breakthrough infections and making treatments contingencies for your patients who may have received Evusheld. However, overall, there is no change in the current recommendation regarding the monoclonal antibodies or antivirals. We'll continue to monitor the guidelines and the frequency of variants. But because the BQ subvariants are from etiologically the lineage of what we've been seeing in the Omicron 4 and 5, there's the likelihood that the updated booster, we're grateful to have the bivalent in the United States, would be effective against those subvariants. Not the case in parts of Europe where their boosters don't have the S spike protein from the Omicron variants. Next slide. And so finally, a summary of some of the public health officer orders and major policy updates since you last heard from Dr. Pon. She went into detail on the healthcare worker vaccine requirement, lifting of the mandatory testing of unvaccinated staff. There's also an updated guidance on the use of face masks that is now tied to the CDC community levels. Currently, we're all in green, but that could change later on in the winter season. There was a revision of mandatory reporting results by healthcare providers and an update on the definition of close contacts. Next slide. So a few moments on monkeypox or Mpox. As a reminder, this is a rare illness caused by the orthopox virus related to smallpox, and symptoms are similar to smallpox, such as fevers, body aches, characteristic rash on the face and arms, rashes that can involve the palms, and that in general, the illness lasts 2 to 4 weeks, and it's not easily spread between people, but it can spread through contact with bodily fluids, lesions, or contaminated objects, as well as through large respiratory droplets that don't travel more than a few feet. We have updated a lot of our provider guidance in terms of medications and clinical guidance, and I'll share those links in a moment. Next slide. We did want to update you on the overall counts. And so globally, there are, as of November 3rd, 78,000 confirmed cases from 109 countries. There's been 40 deaths globally. And within the United States, 28,000 cases in 52 states and territories and districts, with 8 confirmed deaths in the United States. And here within California, having a large share of the overall cases, about 5,500. This is spread throughout California in more than 45 local health jurisdictions. 54.8% of the cases are seen in first Los Angeles and then San Francisco. The others in the top 5 would include Riverside, San Diego, and Orange County. A couple hundred hospitalizations and only 1 death. Higher risk in those who are severely immunocompromised, including untreated HIV. The links at the bottom there are updated in terms of guidance for providers, frequently asked questions, questions about therapeutics as well as vaccinations, dosing intervals. And so I'd encourage you to take a look at that, as there have been some notable changes in the prior weeks. Next slide. From an equity perspective, again, as the Office of Health Equity, we're supporting all aspects of all communicable diseases and other emergencies that we're dealing with. And so when it comes to our Mpox case data, you can see disproportionality here in terms of most notably Latinos and Black African Americans, Latinos being just under 40% of California's population, but having 44.6% in purple of the cases, and for Black African Americans being 5.7% of the population in gray, but in purple accounting for 12.9% of the people diagnosed with Mpox in California. Next slide. What's more concerning is the disproportionality of those who have received the vaccine. And you can see an even wider gap here, that of those Latinos that you see, the 44.6% in purple, in gray, only 26.8% of those who received the vaccine identified as Latino. And similarly for Blacks, in purple being 12.9% of people who have been diagnosed with Mpox, but only 7.2% of those who self-reported their racial identity as receiving the vaccine. So a lot of work ahead, and we ask for your partnership in this. We're working to ensure that all people at risk for Mpox have access to the vaccines, regardless of their race and ethnicity. To that extent, we've launched a brand new Mpox equity website just last week. You can access it at the link below that this data comes from, hot off the presses. And it also goes into some of the things we're doing, such as having an anti-stigma campaign, listening sessions with community groups. All the links are on that webpage, as well as, that may be of interest to you all, interim guidance on the intradermal administration of the Jynneos monkeypox and smallpox vaccine. This was initially recommended to extend the scarce resource supply, and it's been updated to be more permissive for the subcutaneous doses. This is to reduce some of the potential barriers and equity concerns for keloidosis, and so we're being a little more open around the guidance in terms of the subcutaneous versus the intradermal, given feedback from some communities we've engaged with. Next slide. Just a moment of an update on Ebola. Next slide. And so as a reminder to the clinical community, CDC put out a health alert network on October 6th regarding an outbreak of the Ebola virus disease in central Uganda. Hadn't yet spread to Kampala, the capital. And of the 6 strains that are out there, 4 are known to cause disease in humans: Zaire, Sudan, Thai forest, and Bundibugyo. Of concern, this outbreak is of the Sudan strain, and currently there is not an FDA licensed vaccine or treatment for the Sudan virus infection. But as of now, from data of November 1st, California is monitoring travelers. There's some designated airports for returning travelers from Uganda, none of which are in California. And currently in the United States, there are 0 suspected, probable, or confirmed Ebola virus disease cases related to this outbreak at this time. But just for your awareness, wanted to share some of the symptoms and the update on this particular strain for the outbreak. Next slide. So we've talked about various emergencies, and I'd like to shift our attention to the greatest public health and health crisis of our times, of our century, and that is the climate health crisis. I'll be talking a little bit about climate action for California health professionals and giving a summary of the session that was held in late October, hosted by CMA. Next slide. So there's a link to the recording in the bottom right here. That's on YouTube of the entire 2 hours on October 21st in Southern California. I had the pleasure of kicking off this great 2-hour panel discussion around understanding the climate health crisis and how California physicians can make an impact. I'll give you about 2 minutes of summary of the 2-hour session, the best of. Next slide. So here you can see one of our elected leaders, Assemblymember Luz Rivas, who's been a champion on this issue. And she said to CMA leaders, you can see myself there, as well as Dustin Corcoran, your CEO, a room full of CMA leaders and diverse range of speakers and panelists. And Assemblymember Rivas said, if CMA came to Sacramento to lobby me on certain climate bills, it would make a big difference. Next slide. I'll share some of the overall quotes as a best of from the event. So Dr. Lisa Patel from Stanford, who also is the executive director of the Medical Society Consortium on Climate and Health, said that health professionals are uniquely trusted messengers, and our voices are powerful in advocating for climate policies in the interest of health and equity. Climate change threatens our care delivery, and climate policies have immediate health co-benefits. Jason Vargo, a senior researcher on the costs of climate change on health, who works at the Federal Reserve Bank, spoke about how while we do have some estimates, they aren't as accurate as they need to be in terms of quantifying the cost to health and health care, and making the healthier, low carbon option the easiest option for health systems, for patients, for staff is needed to catalyze action. Deborah Gorman, who's the president and CEO of the Green Lining Institute in California, spoke about historic redlining and environmental pollution and injustice. This is part of the cumulative burden that Dr. Bombs will talk about as well in terms of the risk for exposure based on place that can set the stage for disproportionate aspects of additional climate burdens like wildfire smoke or additional communicable diseases like COVID on top of existing structural discrimination. But she spoke about how CMA can advocate for health equity via legislation to solve climate change, and to do so working in coalitions. There are existing coalitions with policy platforms like Charge Ahead and Energy Efficiency for All, and these can be ways that the health profession can really support our patients and our practice. And finally, Walt Vernon from Mazzetti Climate Action Consulting. He is affiliated with the National Academy of Medicine and the Climate Change Grand Challenge, spoke about how we are part of the problem and need to be part of the solution. As mentioned, as we speak in Egypt, global leaders are gathered with the United Nations, and within the United States, the healthcare sector contributes 8.5 to 10% of all greenhouse gas emissions when you include our supply chain. And so we can be part of the solution when it comes to decarbonizing our sector. There have been pledges and you can still do inventories, and I'll talk about that in a little more detail. But one thing is to map out your inventory and move towards decarbonizing. And there's a lot of resources out there to make the journey easy. Healthcare Without Harm, the Federal HHS Office of Climate Change and Health Equity has webinar series that are recorded on how you can do this. And there are other consultants that can assist in taking that inventory. Next slide. So the AMA is not shy for naming a public health crisis when they see it. In June of 2016, they named gun violence a public health crisis, and almost to the day, 6 years later, this June in Chicago, the AMA adopted a new policy declaring climate change a public health crisis. And their board member, Dr. Levin, said that the scientific evidence is clear. Our patients are already facing adverse health effects associated with climate change, and like COVID-19, the climate crisis will disproportionately impact the health of historically marginalized communities. So taking action now won't reverse all of the harm done, but it will prevent further damage to our planet and our patients. Next slide. This was incredibly important because just a few weeks later, it set the stage for the AMA president to speak about the EPA's limiting of regulation on greenhouse gases and how this harms our patients as health professionals. So these declarations matter and can have a positive domino effect in terms of advocacy on public policy for health and climate and overall well-being. Next slide. So this is, again, not something that's new to the CMA. They have over 10 pages of existing policy, and that's a hyperlink if you want to see all the existing policies that relate to climate change and air pollution. This really sets the stage for CMA to both in the Greater House of Medicine with AMA, but also in Sacramento, have an important role for policy. And myself, coming from Contra Costa as a deputy health officer, have been supporting the local health officers and their association. And for the past 3 years, including just last month, they voted to make climate change one of their top 3 priority areas for 3 years in a row. So this is something that the CMA could consider as they focus on legislative priorities. Next slide. Here are CMA members and the board chair with our governor in Vallejo signing Senate Bill 1137 on health and safety setbacks, not having oil and gas extraction within a certain number of feet of homes and schools and childcare centers. And thanks to CMA's support on a policy like this, this is just one of many potential examples of how the power of the health profession could support advocacy. Next slide. So the CMA, as well as the AMA and 200 other health organizations, have signed on to this U.S. call to action for climate, health, and equity. Within our state's administration, this work is centered in our Office of Health Equity that I lead. And we're really asking the healthcare sector to join us in all aspects of these climate actions. Next slide. You can see that last September, more than 200 medical journals wrote editorials that this is the greatest health crisis of the century. And there's numerous studies, including from the Lancet Countdown, documenting the impact. Our governor has named it as a top threat, combating the climate crisis. Next slide. And what we're going to learn is that health has a unique role to play. Just 2 weeks ago, the Lancet announced their America's 2022 report, and you'll see in purple that elevating health is essential. As the world faces a critical juncture, a health-centered, aligned response to the compounding crises can still deliver a future where people can not only survive but thrive. This is why we're asking healthcare's leaders to really support zero emissions in the energy and the transportation sector, limiting fossil fuel development and phasing it out with a just transition, and adapting both our plants, our sustainability operations, and communities to support our patients for adaptation and resiliency. Next slide. So you may have heard the epidemiological transition. I learned at my first day of public health training. And even though I spent the majority of my time talking about communicable diseases, last year in California, chronic diseases still killed more people, with cardiovascular disease and cancer being the top 2 causes of mortality, overall even more so than COVID. And what we see is there's a new third CD on the scene, which is climate disease, as an amplifier and magnifier of both communicable as well as chronic disease. Next slide. The CDC put out this infographic, and we could have an hour of CME on any color, If you just take vectors on the right with Lyme disease or coccidiomycosis valley fever, we've gone from 1,000 to 10,000 cases in California per year, and that's likely an undercount. All organ systems, all of our specialties, A through Z, whether it's you're an allergist or you're a zoonotic infectious disease specialist, climate change is in indirect and direct ways affecting the health of our patients and affecting our practice. I'll spend a hot minute talking about heat, but Dr. Bombs will go into more detail in the bottom left on wildfire smoke and the health implications. And my team added this pink ring in adapting this infographic in terms of the mental health impacts. There's still a lot of research that needs to be done to understand the impact on stress, depression, post-traumatic stress disorder, strain on social relationships. So that's an emerging area of research, and we'd love to come back in the spring and do a deeper session on the other impacts of climate change on multiple aspects of the health of our patients. Next slide. So the costs are huge. If you just take heat alone, it's estimated by 2050 in California, we could be looking at more than 11,000 premature deaths with the price tag of $50 billion. Specific to healthcare, we can see premature deaths, medical care, rehabilitation. There's an impact on home health. Medications will be disrupted, lots of interactions in terms of the liver and kidney, lost wages, worker productivity, and downstream health costs as well. Next slide. And this is not theoretical. During Labor Day, we faced a 10-day extreme heat event, unlike anything that we've seen. There was a proclamation of a state of emergency. We activated our emergency systems. Our electricity grid was pushed to the brink. There was concern of power shutoffs, which we've seen before, which of course impacts our patients on home-dependent durable medical equipment. Next slide. And in my Sacramento office, we broke the record at 116, but it was throughout the state, as you see on the right, records were broken. Next slide. And this will only continue. It will increase in frequency as well as intensity in terms of heat alone, which compounds drought, wildfire risk, and other aspects of that circle that you saw. Next slide. So the health message and the health messenger is essential to solve this global and California climate health crisis. On the right, you can see in green that health professionals, doctors, nurses, and pharmacists are the most trusted by the public at a time when trust is at an all-time low. You can see members of Congress are right next to car salespeople in the bottom part of the right side of the graph. But for the first time, health has surpassed jobs as the reason that Americans and Californians too, when surveyed by Eco America, support climate solutions. And 68% of Americans trust health professionals, which is why we're asking, no matter your specialty or role, you all to be climate ambassadors. Next slide. So our nation's top 2 leaders when it comes to health came to California recently, and I'm passing on a message directly to you from them. First on the left is Dr. Rachel Levine, Admiral, Assistant Secretary of Health, former health officer of Pennsylvania and an adolescent medicine specialist. And she talked about the healthcare sector needing to decarbonize. More than 50 healthcare sector institutions in California alone have taken this pledge. And on the right, you can see Secretary Becerra asking California to take a lead when it comes to equity in particular. Next slide. So I'll end with some action steps here on how you can become a climate-focused physician and be a trusted messenger, talk about it with your patients and join organizations, be a climate champion within your organization. Next slide. And also support your organization in becoming a climate-focused healthcare organization by appointing individuals, having climate-smart policies, and offering incentives for employees to decrease the carbon footprint, and taking benchmarking tools to really get a good inventory of what you're doing. Final slide is the next one, which will show you that overall next week, there's an opportunity to join Climate Health Now for a community meeting, and the link is available there. And next month, CMA is having a climate champion group where you can get to know your peers who are interested in this. In February, you can speak with your leaders on the Council on Legislation, and there's a webinar series from our federal HHS on how you can support decarbonization. In the next slide, you'll see that we put out a brand new resource from August from CDPH on wildfire smoke. Next slide. This just details what's in that August update. It talks about many of the things that Dr. Bombs will go into detail, but I just wanted to share this with you as an updated reference for many of the questions that you submitted. Next slide. And here in the final one, you can see that there are many resources that are referenced here. Again, the questions that you submitted got into a lot of details for schools and children, and we reference a lot of national working groups that offer our best recommendations with the science at hand. And with that, we'll move to Dr. Bombs to go into more detail. Thank you so much.
Thank you so much for that incredibly detailed talk, Rohan. Dr. Bombs, we're so grateful to have you and your cat join us today.
Actually, the dog.
Oh, sorry, I just saw tail. Anyway, let me just quickly introduce you because you have a very exciting history. John Bombs received his MD from Mount Sinai School of Medicine and then did some research at Yale and joined the faculty of UCSC and then moved to UCSF. He's currently the professor in the divisions of occupational and environmental medicine and pulmonary and critical care medicine. We seem to have lost a John and gained a Rohan. There we go. But what's exciting to me, besides many other things about Dr. Bombs, is that he's served as directors of a variety of different institutions, but done some very exciting research around the world. He has a body of research that includes looking at ozone-induced airway injury and inflammation, the impact of air pollution on the health of children living in Fresno, the effects of biomass smoke exposure on chronic respiratory health of children and adults in rural Guatemala, Malawi, Nepal, Rwanda, et cetera, et cetera. So I encourage you to look up Dr. Bombs' bio online, but I just want to go right into having him give a talk right now. And Dr. Radhakrishnan and I will disappear while he gives his talk. So thank you so much again for being here.
Thank you, Kim. And as she already mentioned, the rain that we're currently experiencing in California probably is putting an end to this year's wildfire season, but we expect more in future years. So could I have the next slide, please? So hopefully the background noise from my gardeners just happened to come at the wrong time isn't too bad. I will move if it is, so let me know. So the fire that really got the state focused on the health impacts of wildfire smoke was the Camp Fire in November of 2018, almost exactly 4 years ago, where unfortunately the town of Paradise was literally destroyed by the fire. And in the bottom right, you can see a satellite photo of the plume of smoke from that fire going down the Central Valley and out the Bay Area. And the air quality that was measured during the Camp Fire was the worst that had ever been measured in California. Next slide, please. And then a couple years later, we had the horrible month from really the second week in August through the first week of September, where the entire West Coast was really blanketed by wildfire smoke. So this is now not just California, this goes all the way from British Columbia down to Mexico, and every one of those red dots is a wildfire. And you can see the plume of smoke. It was just terrible. And some of you who live in the Bay Area will remember September 9th of 2020 when the sun looked like Mordor. For those of you into Tolkien and the Rings of Power, we literally had a dark morning because there was such bad wildfire smoke. Next slide, please. So 2021 was also a bad wildfire year, and there was the Caldor Fire, which caused the evacuation of South Lake Tahoe, and then the Dixie Fire, which actually was still burning when the Caldor Fire erupted. And the Dixie Fire is to date the largest wildfire in California history. Next slide. And just to show the trend over the last few decades, you can see that the acres burned have generally been going up. You know, we have good years, like actually this year is not anywhere near as bad as 20 or 21. And, you know, it's all dependent on the weather. And, you know, thank God we got a rain, a pretty good soaking of rain these last few days. Next slide. So why do we have bad wildfire years? It really is climate related. And this is just showing the difference between 2019, which was a pretty good year in terms of wildfire, and then 2020 in February of those years. And you can see the snowpack in 2019 in the Sierra was pretty impressive. And in 2019 and 2020, there's hardly any. And that was also the case for this year. We really lucked out because we didn't have the snowpack and water reserve that, you know, we might have hoped for. But fortunately, the wildfires weren't that bad this year. Next slide. So I just want to remind you that wildfires due to climate change are a worldwide problem. They have occurred in Russia, in Portugal, in Brazil, and Australia. The 2019-2020 fire year in Australia was really bad, and literally, yeah, thank you, and push, thank you, keep going. I forgot that I have animation here. So many millions of animals died, and unfortunately a number of people as well, but 46 million acres burned that fire season in Australia, which was 10 times what burned in California in 2020, which to date has been our worst wildfire year in terms of total acres. You can see the satellite photo on the bottom left. You can't even see New Zealand in that that particular photo because the air quality was so poor. And you know, there was a lot of health problems occurring during that wildfire episode of multiple days, including the Australian Open. The tennis professional open was occurring in Melbourne at that time, and some of those professional athletes actually who didn't have a history of asthma were actually wheezing because of the poor air quality. And it was also really hot. And that just reminds me to say that often wildfire episodes occur when there's a lot of heat and also a lot of ozone. So there's kind of a trifecta sometimes in California of multiple air pollutants and heat. And just to remind you that wildfire emissions actually contribute to climate change. They're not just causing health problems. The Australian Environmental Protection Agency estimated that the climate forcing emissions during the 2019-2020 fire season equal to a whole year of man-made sources. Next slide, please. And this slide goes into that about how wildfire emissions have multiple impacts. So you can see that the emissions lead to poor air quality and health impacts, which I'll talk more about in the next slides. But there's also a feedback loop. There are climate forcing emissions, such as nitrogen oxides, the generation of ozone, and black carbon itself. Next slide, please. So what are the emissions from wildfires? There are primary air pollutants, and we focus on particulate matter because that's what we see in terms of that smoke plume from the satellite views. And also we know a lot about the health effects of fine particulate matter, PM 2.5. But in the vicinity of the fire, there's high carbon monoxide levels, and that's caused problems when you have these wildland urban interface fires, like I showed you the town of Paradise being wiped out, or the Coffee Park neighborhood in Santa Rosa was also destroy. People actually had elevated exposures to carbon monoxide. Whenever we have combustion in our atmosphere that's nitrogen rich, 80% nitrogen, we develop oxides of nitrogen. They have direct health effects, especially with regard to asthma. And polycyclic aromatic hydrocarbons, PAHs, are some of the nasty cancer-causing agents in tobacco smoke. And then also volatile organic compounds like benzene or formaldehyde are both carcinogenic and directly irritating. So I like to think of wildfire smoke as similar to tobacco smoke without the nicotine. But there's also secondary pollutants generated from these emissions. You know, nitrogen oxides generate ozone. So wildfires generate ozone. And like I said, there might be high ozone levels just because it's hot when wildfire occur. And then there's secondary generation of particulate matter also from oxides of nitrogen. So next slide, please. So going back to that horrible month in 2020, from early August into early September, Marshall Burke at Stanford did a nice study where he showed excursions above the baseline in 5 metropolitan areas in California due to the wildfire smoke. So the zero line isn't 0 PM 2.5, it's the baseline from 2015 to 2019. So Fresno, which has some of the highest PM 2.5 in the state and country, that zero isn't 0 PM 2.5. It's probably, you know, around 12 or so. Anyway, these excursions, the red peaks above the zero line, are due to the wildfire smoke. And could I have you push the next slide? Should you? So Marshall Burke estimated there were 1,200 to 3,000 excess deaths due to these excursions. And how did he come up with that number? There's very robust data supporting exposure to PM 2.5 and mortality, mostly due to cardiovascular deaths. So this is just from 1 month of bad wildfire smoke exposure. Next slide, please. And I was involved with a critical review of the health impacts of community exposure to wildfire smoke that's now a bit out of date, but I like to use it because it was a collaboration with the British Columbia CDC, which has been very concerned about wildfire smoke exposure in the British Columbia population, and they've done a lot of good work in that regard. So I also like to show this photo, which was not part of our study, because this is a Latino family during the Thomas Fire in December 2017, walking in Santa Monica, and you can see that there's smoke in the background. They're all wearing N95s. That's good, except N95s haven't really been approved for kids, so I don't know how well that's fitting, that young girl there. But maybe they should be inside instead, in a clean room, rather than being outside. Next slide, please. So there's clear evidence of an association between wildfire smoke and respiratory health. Almost every study. This slide comes from our work that was up through 2015, but there have been multiple studies since that have shown that asthma and COPD patients have exacerbations during wildfire smoke. And there's a growing evidence of link between wildfire smoke and respiratory infections. And I'll come back to COVID, the respiratory infection of major impact now in a later slide. Next slide, please. So this is a relatively recent paper that came out of Scripps in San Diego, and they were able to study virtually all pediatric respiratory health care utilization during a period 2011 to 2017 in San Diego County. And they showed that when there was wildfire smoke PM 2.5, that there was a greater effect on healthcare utilization of kids for respiratory outcomes than due to non-wildfire PM 2.5. A 3.7% increase with non-wildfire PM 2.5 levels, and a 30% order of magnitude greater with wildfire smoke PM 2.5. Next slide. I'd like to highlight this slide, this study from, it was published in 2018, but it was the 2015 wildfire season, which wasn't even a particularly bad wildfire season. And was a collaboration between Zach Wettstein, who was a UCSF medical student at the time, Dr. Hoshi Ko from the California Department of Public Health, and then Wayne Casio and Anna Rapold from the US EPA. And they showed that it wasn't just respiratory health outcomes, that they found the expected healthcare utilization for respiratory problems, but they found what was then relatively novel, an increase in cardiovascular outcomes, heart attack, heart failure, stroke, related to wildfire smoke exposure. And again, this was 2015, when it wasn't as bad as what we currently have. Since that time, multiple studies have also shown this effect, both in the US and Australia, but this was one of the first studies to link wildfire smoke exposure and acute healthcare utilization for cardiovascular outcomes. I'm running out of time, so I got to speed through these. Next slide, please. So I just want to show that based on what we know about non-wildfire PM 2.5, which is, 2.5 microns or smaller particles, make it down into the deep lung, there is a robust literature for low birth weight, for metabolic outcomes, for child neurodevelopment, cognitive decline in old folks like me, decreased lung function, health of pregnant mothers. We don't have data for wildfire smoke yet, but we expect that there will be these kinds of outcomes from wildfire smoke exposure, especially with recurrent, longer periods of exposure that we expect in the future with climate change. Next slide. And I wanted to probably end with talking about COVID, because this study from Harvard investigators, who are some of the first investigators to show a link between non-wildfire PM 2.5 and increased risk of COVID mortality, they then applied their methods to studying excess COVID-19 cases as well as deaths due to wildfire-specific PM 2.5 in 92 counties in Washington, Oregon, and California. And they did find an increased risk related to wildfire smoke exposure, which is what we expected. Next slide. And as Rohan mentioned, there's an updated version of this guide for public health officials related to wildfire smoke that just came out in August. I need to update my slide, but it's important that we be ready as both a public health system and as individual healthcare providers to be able to deal with the health effects of wildfire smoke on our patients. Next slide. I want to end with this one. So how can we help our patients? We can remind them to stay indoors with the windows closed, to shelter in place during bad wildfire smoke episodes. And even better than just staying indoors with the windows closed, having building, which would be a MERV 13 filter in a home that's centrally ventilated, or room filtration with a portable HEPA air cleaner, as shown on the right. If people have to go outside, like outdoor workers, like farm workers, construction workers, or even people having to go to their jobs, an N95 is the best mask to wear. And I show an N95 with an exhaust filter. These are not appropriate for healthcare workers, of course, because there's an exhaust valve. But for prevention of wildfire smoke exposure, these are actually more comfortable and are perfectly fine, because it still will filter air going in, but allow people to breathe out. Especially persons with heart and lung disease should wear N95s if they have to go out. And especially children as well, even though they're not currently approved for children. That's coming. And I think I'll stop there. Thank you.
John and Rohan, I wish we had more time today. We had so many questions, but you actually addressed many of the questions that our viewers had already. I'm super grateful for you both for being here today. And thank you to everyone who joined us today for listening in and taking the time to learn from our webinar. I will mention our next session will be Tuesday, December 13th, where in addition to updates on COVID-19, we'll spend the whole time talking about some emerging viruses, not only including monkeypox, but also some interesting enteroviruses that are getting quite tricky, and polio. So more information on that is available at our website, www.covidroundsca.com. And just remember, when the survey sent around at 5 p.m. today, if you want CME, please do attest to your attendance and we'll send you your certificates. We'll also have all the great information, the slide deck with all the links in it from these speakers today, so you can research more. Thanks again to everyone and have a wonderful week.